All right. Well, welcome everybody to our September 12th, 2019 Maine Local Government Human Resource Association meeting. I'm Erica Helgerson. I'm the Assistant to the City Manager and Director of HR with the City of Bath, and I'm standing in stead of our President, Don Brewer, and I've been the Vice President for several years now. But this was the first time I've had the chance to run a meeting because Don has been so dedicated, he hasn't missed a single one. So welcome to everyone who showed up today in person here in Auburn, and welcome for the first time to all of the people who are going to be watching on YouTube with our live stream, or people who might be able to catch it later. We're really excited to be able to finally put this out online and be able to accommodate some of the folks who live further away who can still access this information and get value out of this group. We know it's really hard to get to all of these meetings if you live in a place that's much further away. So please let us know out there in cyberspace how this worked for you, and whether there's other things that we can do to make it easier for you to be a participant. We have 3 speakers today for our presentation from Maine Municipal Association and the Health Trust. Christy Gould is the Assistant Director of the Health Trust Services at the Maine Municipal Employee Health Trust, and she's going to inform us what's new and happening at the Health Trust as we prepare for the fall benefits open enrollment season. And for those of you who are newer members or who aren't aware, Christy was also a longtime municipal government HR director and was actually a founder of this group. So thank you so much, Christy, for initiating all of this, and and now we're up to over 100 members, which is really, really awesome. So thank you for all of your work with that. And Matthew Pitcher, is our MMA Workers' Compensation Claims Supervisor. Tracy Gould is the Assistant Claims Manager, and they're going to provide a brief overview of new workers' comp developments, changes to the wage statements for workers' comp claims, and the Workers' Comp Board has adopted strict policies on wage statements and their timely filing, which include monetary penalties if not done timely and correctly. So pay attention. So with that, I'd like to welcome Christy to come up to the podium. Thank you.
Hi, everybody. I'm going to try and use this this microphone. Okay, there we go. Use the microphone for the recording. I don't stand still well, so okay. So glad to see so many faces that I've worked with over the years, and then some new ones as well, and I'm thrilled to see the membership of your group being so successful and hopefully adding a lot of support to people who handle HR, who don't necessarily have the title HR. And a lot of you, of course, are members of the Maine Municipal Employees Health Trust. We certainly have the majority of communities in the state, not all. So if your group is not a current member or you don't participate in health, most of this may not apply to you. But we're certainly happy to share information. I'm going to give a brief overview of what's going on with the Health Trust and some updates and a few things. So I guess some slides. If you did not get slides, did anybody not get a copy of the slides? Okay, anybody else? Erica. Okay, so I have some other goodies up here on the table too, and I'll tell you what they are. We don't go anywhere without paper. Sorry. And notepads and pens, give-me's, right? Okay, so today, there we go. So today, there we go. We're going to give you a few strategic updates, just things I've talked about in the past that I'll kind of let you know where we are with them. So some of our strategic initiatives. Talk a little quickly about claims and cost trends from last year. And then I'm going to tell you about plan changes that will be effective January 1, 2020. Someone in your organization, the key contact, should have received a letter at the end of August with that information in it. I know that doesn't necessarily always make it onto your desk, so I have copies of it, but I will also share that information with you. Not a lot of changes for next year. We'll talk about some what I call bonus benefits or programs that I really think it'd be great for us to do more to let employees know about. They can take advantage of. They're free, that we're just trying to increase the education about. And then I'm going to just run through some common issues and tell you the dates for the upcoming open enrollment. So some of the strategic things we've been talking about for years, we've had this shift going on where people are moving from our higher priced POS plans to the lower cost PPO plans. And this means they shifted to plans that have a lesser or less rich benefit, and also have lower premiums with that. Obviously, we're all looking out. We have to do our due diligence and watch our budgets with our, taxpayer-funded money. So everybody's being very careful to look for the best value. So that shift continues, but it has been slowing down somewhat, as a lot of people have already moved to some of the PPO 1500 or the PPO 2500 plan. So we expect that still to continue. The most populous plan that we have now is still POSC, but only by 20 people. PPO 500 will replace it pretty quickly as the most popular plan. That's my bet anyway for the next year. And we are anticipating and expecting to do a new plan. It'll be coming out sometime in the middle of 2020 or in 2021. We will not be doing it at a January 1 open enrollment. It's not a good idea to throw all of it at once with our limited staff and your limited resources as well. But we will expect to have a new plan. It will not be a HSA compatible high deductible health plan. There has been some discussion of that, but as we've surveyed our groups and talked with people, we've discovered that people are looking for additional value, additional plans that are lower premium that they can pair with an HRA, which most of you are doing, but the desire to have those plans that are really high deductible, where everything goes to the deductible, once I explain to somebody how those work, they usually go, yeah, no, I don't think my staff is ready for that. Okay, so though we talked about that, that is not in our plan at this time. Consumerism, obviously these plans with higher deductibles and more cost shares for employees, it puts a little more of the burden on the employees to pay costs. So those plans are expected to have some consumerism, some people thinking a little bit more and shopping around a little bit more for their care. We are seeing more of that happening, but it's still a lot of times people, they trust their doctor, they go to their doctor says go here, they go here. So we're looking at some programs that might help direct people to places where they could get quality, low care at a better value without having to go too far out of their way, and just to educate them on that they have options in healthcare. A lot of people don't. How long do you spend looking for a new TV? Right? People get on the websites and they go to consumer reviews and they go to all these stores and price them out. But if you need to have, a medical service, especially an elective one, they just go, okay, to the local place, and that might not be their smartest option sometimes. And then HRA utilization is definitely still increasing, especially with a lot of our larger groups that are using what's called a health reimbursement arrangement to go along with one of the higher deductible plans. We're seeing more and more groups covering the deductible, but also the co-insurance for the employees. That's a way that they can sometimes get them to move, and I know that's a negotiating tactic, and sometimes to pay that for the employees. We do have concerns with paying all of the cost for the employees so that they don't have any skin in the game towards it. It kind of takes away some of the built-in consumerism that's expected in those plans. So that's one of the reasons we've had problems with the plans, the lower cost plans they're not adequately priced to be able to pay all the claims that come in for those plans. So that's that rate relativities section, okay? If you've read any of our letters and communication in the last few years, we've talked about rate relativities, which is basically how the plans relate to each other. And we have had to have additional surcharges, if you will, or additional assessments on the lower cost plans, so their rate increases have been higher than on the POS or the higher cost plans, to be able to try and fix that problem and move it so that the lower cost plans the relativities are more even across the pool. We don't expect that any plan is every single plan is always going to break even on its own. We are a pool, right? So everybody's intrinsically subsidizing everybody else at the health trust. We're a self-funded pool. So, but we are looking to make sure that the employees in certain plans are not overly subsidizing employees in other plans, okay? So we're still continuing to work on that. We've gotten much closer and made great progress over the last few years with a strategy of targeted benefit plan changes that impact members in those lower cost plans a little more, to change the relativities that way, and also with the strategy of the additional rate increases on those plans. So we're getting close to where we need to be. We think within a couple of years that we'll be able to, hopefully we won't be doing that additional strategy for those plans anymore, and we'll be where we need to be. And then it makes sense to add a new plan. It's hard to add a new plan and price it appropriately if your other plans aren't already. Okay, so that's what that's been about. So medical and RX trends, you guys see the news we see. So certainly medical trend is still going up, though not as at quite a clip as it had in the last couple of years. And prescriptions are just all over the news. I think more and more members and consumers are starting to really be aware of prescription costs, which is good. So some of the things that we have seen, last year we had a really big year with high cost claimants. One of the largest we'd had in a long time. Now, the trust has what's called a reinsurance or stop loss insurance, where we have basically, it's just called a stop loss attachment or a deductible of a certain dollar amount, that after that we have insurance that pays the difference. So it kind of protects us from some of these really big claims and swings that we might have with that, okay? That deductible is $500,000. That was increased last year. Last year, we had 8 claims that were over that $500,000 amount. And we had 4 claims that were over $1 million, okay? It's the first year we'd ever had 4 of them, went to $1 million. So it's the cost of healthcare, okay? And the great new technologies and advances that are coming along, but they do come with a cost. So 466 claims were over the $50,000 amount last year. That totaled $55 million worth of our claims, okay? So it's a larger percentage of the claim money goes towards a small percentage of claims, but they are of larger amounts. So just to be aware that we're watching that, and it's definitely a trend we're seeing towards bigger dollar amount claims. So, but we do have that reinsurance to protect us from some of the swings that would happen from paying those. And prescription trends, more and more new expensive specialty medications are coming on the market. Some of these are amazing advances that actually cure disease. You know, they don't just treat, they actually cure some diseases. A good example of that's hepatitis C, where the drug is very expensive, but a 6-month treatment usually 90-something% of the time cures someone of the disease. So we talk about the cost of the drug and how expensive it is, but have we also maybe started to see our medical not rising as fast because drugs are making it so that person doesn't have further issues and troubles and that will land them in the hospital later, right? So it's you have to kind of balance off where we're paying very expensive medications, but if they are keeping people from having to have expensive medical care, then they could be very much worth that, right? So, but we are certainly watching that, and prescription drugs is becoming a larger and larger percentage of the pie every year. Last year, prescriptions themselves, just not the administration of them, but just prescriptions themselves was 19.9% of what was paid. So it's a lot. 20% of everything for claims was in prescriptions. So, and that does not include prescriptions that are administered in a hospital and such. It's you went and filled a prescription, okay, or a specialty medication at a specialty pharmacy. So, this way. So plan changes. Oh, I got something going on here on the side. Okay, so the plan changes effective January 1. There are 2. And the first one is an actual reduction in the copay that members pay for urgent care. So this needs a little bit of explanation. We have done a lot of education, and I know you guys have as well, to talk to employees about the value of using a walk-in center, okay? And more of those are popping up all around the state. I actually have the newest list here if you want to take one, but it's on our website right on the homepage, because we're really encouraging people to use the appropriate site of care for the issue they have. And a lot of time, that's not the emergency room, which everyone knows is the most expensive intake, place you go to present for health care. So as more and more of these centers are opening, and they can do more and more things, they really have some very nice advancements in some of these new centers, we want to let people know that that's a place they can go. So right now you pay a specialty copay if you go to a walk-in center, okay? There's this third level, though, called urgent care, that there's actually only 2 or maybe 3. There's 2 true urgent care centers in the state, okay? And then there's one that bills as either a walk-in or an urgent care based on what you get for services. But urgent care is, like in Booth Bay at St. Andrews, is an urgent care facility, and the other one is, I'm blanking right off the top of my head, but I'll remember before it's over, I'm sure. But the urgent care facility, it's not that I really want to encourage people to go to urgent care. My concern is a lot of these new walk-in centers that are opening have this big sign that says, Convenient MD, urgent care, right on the sign. Or you go to their website and they say they're an urgent care facility. But if you go to our plan design document right now, our summary sheet, or you go on the website and you look to see what it's going to cost you to go to urgent care, it says it's the same as an ER visit. So why would I go there if it's going to be the same cost? Okay? The truth is it's not. It's a walk-in center. So the reason we're reducing the urgent care copay is not so much to encourage people to use urgent care, but to reduce the confusion that is around what is urgent care and what is a walk-in center. And if people know that an urgent care and walk-in are the same, they are both a specialist copay, they know what an ER is. The ER is this copay, which is either $150 or $200, significant, okay? But if I go to a walk-in or urgent care, it's going to be my specialist copay, which is anything between $20 and $45, okay? So that's the real reason for that change, and we've reduced the urgent care copay to encourage people to be able to use walk-in centers or urgent care. Does that make sense to everybody? Do you think you can explain that to your employees? Maybe not, but anyway, it's still a good thing that we're reducing the copay for anyone who would go there. The other change is an increase in the overall out-of-pocket maximum. So this can be very confusing because the out-of-pocket maximum, which is near the top of the summary chart if you're thinking about that, includes the deductible and the coinsurance. But we also have an overall out-of-pocket maximum, which includes copays, okay? The Affordable Care Act put in a limit that you could have as an overall out-of-max on plans. Ours is still significantly lower than what the ACA allows. But we have had a $63.50 limit on all plans, okay, right, for the last several years. It hasn't changed. So the out-of-pocket maximum they're used to, which is their deductible and coinsurance together, is not changing, okay? All it is changing is the total max, so that means that it's hard to do this without your hands. There's buckets, there's deductible and coinsurance, and then the rest of it to come up to that limit number would be what they would have to meet in just copays. So basically the copay max is what's changing, right? We're just moving the goalposts around in there. So the copay max, which if you consider on your plans, it's very high, okay? So for most people, they're not going to hit their copay max. You'd have to have a lot of prescriptions, a lot of therapy, a lot of doctor's visits. To be honest with you, we've only had a handful of people actually meet their copay maxes since we've had this limit in place for several years. So it's going to impact very few employees, very few. But I do want to make sure you're aware of it and understand it. It is not going to impact your community if you have an HRA that covers coinsurance and deductible. We are not changing that max. That changed the year, I think it was 1/1/18, okay? And that was a significant change for a lot of the groups, but that is not what is changing. It's the total out of pocket, Okay? Questions about that? Everybody understand we're trying to explain on that? Chris? Yeah. Well, it does allow us to, we are seeing more people hit it who have the higher cost plan. So if you have a 2,500 plan and your deductible is 2,500 and your out-of-pocket max is 4,500 and the max is 6,350, then your copays is only 1,750 on that plan. So more people were starting to hit it, and as we have more and more people go to that plan, we were going to start to see that keep happening more and more. So this is a way for us to, our strategy is to make plan changes that are targeted, that impact heavy users of the benefit more and everyone else minimally, okay? So this is one of those. And it also, we made it so that it's not the same for all the plans. The POS plan max is now 6,500 and the PPO is 7,500. So it's one more way for us to differentiate those plans, those lower cost plans, okay? Good question, though. You're right. It really won't impact a whole lot of people, but it does impact some if they've had a really, really bad year, really. Okay. So I don't want to minimize that for them, but yeah. Okay. The bonus benefits programs I mentioned, did that again. So these are just some things I'm sure a lot of you might be familiar with, but I want to make sure that you know about. We're going to spend a lot of time at convention, actually. We're going to be focusing on these, what we call bonus benefits. Ann Charles, our health promotion manager, most of you know her. She actually does a class called Bonus Benefits. So if you'd like to have her come and talk to your employees about it, that's something we could schedule. But these are some of the things that people say, oh, I didn't know you had that. Of course, there's a lot of resources on the Health Trust website, and you can get to all of these from there. Okay? The TDES stands for Telephonic Diabetes Education and Support. We've had that program for quite a few years, but I still find people go, oh, you have a diabetes program? If people participate in that telephonic diabetes program, it's a year-long program. They meet with a coach once a month most of the time. We waive their copays for all their diabetes medications for the entire term that they are doing it. And they can actually do a second round of it as well, which is more goal-based for them to try and meet certain health targets to manage their diabetes. So it's as copays and medications get to be a bigger part of people's budgets, that's a program. If you've got someone who's got diabetes and could use some education about it, then I really would encourage you to recommend them to that. They can do the whole thing over the phone now if they prefer. And we do allow retirees to participate. So. Anthem's EAP, I know you're all familiar with employee assistance programs, but the EAP website has the most robust amount of information I've seen. It's just a fantastic resource. People can go there for all kinds of mental health issues, quizzes and assessments. There's templates to do wills. There's a way you can get financial counseling, child care referrals. There's so much more to the EAP than most people know. And I want to remind you that if your group offers medical insurance, everyone who works for you can use the EAP, whether they have the coverage or not. So I know your part-timers don't often get a lot of benefits, but this is one that they can take advantage of, and I encourage you to let them know that. Steph? Mm-hmm. Mm-hmm. Right. Right. We have had some issues recently that we're struggling with Anthem in that they have people in their network, their EAP network, who are no longer participating or are not responding to calls. And that's very frustrating because they have done so much good work for so many of our members have had real value. But we want to make sure, especially when someone's finally ready to pick up the phone and talk to somebody or go talk to someone, that they get a call immediately. So when you call initially, you're going to talk to someone right away, but that's that referral process to the next person is where the letdown has happened. And in some cases, this is the provider's issues. They haven't told Anthem that they've withdrawn, or the communication. So we're working with Anthem that they're vetting the whole network to make sure that everybody is active who's on their list. But we're also creating some methods whereas we can actually call for them and get a already set up provider that then is basically like a pre-approval process. So they have somebody that we know is going to be there for them when they're ready to talk to them. So if you're having any issues, or even if you want to just start first, you're welcome to call me or Ann Charles, and we will call the EAP and make sure that we have someone call them or you directly to make sure that happens, okay? So we're trying really hard to work through those issues with them. But counseling is a big part of the EAP, but there's a lot of other parts too that we're just making sure people know about. Chris? Oh, okay, yeah, okay, great. Yeah, sorry about that, people who can't hear the questions. That question, you probably can tell, was about the EAP network and some concerns with people who are already in crisis and ready for attention and being able to get through to a provider in a timely manner who can help them and assist them. Smoking cessation programs, you guys are probably aware of that, but we do have, it's covered through the medical insurance, so I'll have some flyers about that at convention as well, and remind people when they're ready that there are resources for them. The telehealth is catching on. It's called Live Health Online. The younger generation seems to be much more comfortable talking to people through their devices. Why not talk to a counselor through your device? And that's one of the things we're pursuing with the EAP as well, is having, especially if you're in a small town, if I'm in Caribou, maybe I don't want to talk to the 2 counselors in town who I run into every time I run the grocery store. Maybe I want to talk to somebody from away. But they also do medical stuff. Someone in my office went for a visit. They had a rash while they were on vacation. They didn't know what was, and that's perfect. Talk to a doctor, show them the rash, get a prescription, move on. Okay, so it's a good program, but it is highly underutilized. 24/7 Nurse Line is another one that's pretty underutilized, but again, in the middle of the night, baby's got a fever, perfect place to call and talk to a nurse. Decide before you head off to an expensive ER. Okay. Future Moms is a support program for exactly that, women who are pregnant. So, and they get some books and resources, and all of it's free, and it doesn't get used much. So just making sure people know that those resources are there. And then the HOW program was introduced a couple years ago with the Delta Dental program, and allows people to get extra cleanings and extra treatment if they meet certain risk factors, and those all are preventive services that don't cost the employee anything. So if anybody really loves to go to the dentist, they can go 4 times a year instead of twice. Okay, trying to get through this quick here. So some common issues and things that I wanted to bring up, or let's be honest, members of my staff wanted me to talk to you about. So I didn't say nag, I said talk. Salary changes. We're running into continuously and increasing issues with salary changes not being made and updated, okay? And salary changes need to be reported to the health trust when they happen, okay, monthly or whatever. I don't know how you go about doing it. But the challenge that we're running into is that if people do not update their salaries from last year, and then all of a sudden they have an IPP claim, income protection plan claim, and their salary is still last year's salary, before we can approve their claim and get through the whole thing, I've got to go back and figure out what the correct salary is, and we have to make adjustments, and then we got to go back and adjust bills, and so there's a whole bunch of pieces there, and it slows down the claim when the employee is waiting to get their money when they're on disability. And when they're on disability, it's often a really bad time in their life, and the last thing they need to deal with is insurance claim problems, okay? So keeping the salary changes up to date prevents that issue. We also had a life claim recently where the employee had their salary was actually $20,000 higher than what I had on file. Do you think the insurance company was going to question that? Yeah, okay, so they'd had some significant promotions and nobody had ever reported it, but then all of a sudden the worst happened and they died. And we had to explain to the insurance company why we felt that the payout should be $20,000 more than they thought. So keeping up with the salary changes is very important. And then to remind you that the changes take effect with the trust billing cycle, okay? So if if you send me, if a salary change takes effect October 1st and you send it to me October 15th, but I've already run the November bills, it's taking effect December 1st, not November 1st, okay? So Linda Matt can talk you through that if you have questions about it. If they have a claim, we're known for making exceptions on behalf of the employee, looking out for the employee, but we're trying really hard not to have to make exceptions just because everybody didn't hand in their salary changes, okay? So thank you for your attention to that. PCPs is another one, as we have more and more people on the PPO plans that do not require referrals from a CCP, they assume that means they don't need to have one. I think you guys all know one of the best things you can do for your health is have a relationship with a regular doctor, a primary care physician. So we still strongly encourage that, and we will call people and ask them who their PCP is if they have not listed a PCP. So if you could check your forms when they send it in, ask them to put their PCP down, that would really help, because otherwise we're going to call them. So, and then life insurance beneficiaries. I just had another situation where someone's ex-wife was still listed as their life beneficiary, and that's so challenging to deal with the family members who then think that they should have been the beneficiary and they've got some sort of legal fight on their hands, but I have a form that tells me who I have to pay. So during open enrollment is the perfect time for you to ask everybody to check on their life beneficiaries and make sure that those are up to date. And then the last thing here is the most common question that member services gets is the difference between preventive and diagnostic services. So members call in all the time and they think that they should have not had to pay for labs because they thought they were preventive. So if you go for your annual physical and you have no diagnosis, let's use diabetes as an example. I've never had diabetes. I don't have any issues with that. I go for my lab, they do a blood sugar test, that's preventive, okay? But if I go for my physical and I already have diabetes and they're sending me to check my sugars, that is no longer a preventive lab, it's a diagnostic lab, even though that happened in conjunction with my physical. So those are the kinds of things that we often run into that people do not understand the difference between preventive and diagnostic. It really comes down to, do you already have a diagnosis? Okay. Well, yeah, I mean, but if they don't have it already, it's a preventive test. So most people know what preventive tests are. They're going for their colonoscopy or the mammogram or whatever. But if you've already had breast cancer and you're having your mammogram, is it preventive? So those questions come up often. By all means, have them call member services, okay, and they'll talk through the issues. Mammogram might not be the right one because those have different requirements that they have to, we have to cover those and things. So that's probably not the right example. But the diabetes lab is one that is a better way to explain it. Okay, and I need to turn this over to my coworkers here. So last thing is open annual enrollment. The dates have not changed. We will still be doing open enrollment November 15th to December 15th. The rate setting meeting this year, when the trustees get together to do the rate setting, is in the last week of October. It's actually not till the 28th, okay? So that's later, but that's necessary because finance needs to have all the claim data to be able to do the analysis. Basically, the way we set rates is we project what next year's claims will be, and we determine what we're going to need to have to cover that and any of the costs associated with paying the claims. It's not rocket science, okay? But we can't do that until we have all the claims data. So the trustees are meeting at the end of October. That does put us in a crunch to try and get all of the information input into our system. I know some of you have heard me talk about the challenges we have with their system to do that, and to get all the rate sheets proofed and out to everybody before open enrollment begins. But we will have them out before open enrollment begins, the actual rate sheets. However, you do not have to wait for that. If you are in one of our rated groups, which is 51 members or more, you probably know if you're a rated group, someone will be contacting you as soon as the meeting ends on the 28th. We start making calls. So someone will call your key contact, will be the person who is called. Typically that's your town manager or county administrator or whoever that is. Will be contacted to let them know what the rate adjustments will be for next year. Okay, so you'll have that percentage right away. And the non-rated groups, On November 1st, you're welcome to contact your field service rep, and yes, I have given them the heads up in case they get a bunch of calls, or me, and I'll be happy to tell you what the rate increase will be, the percentage. I cannot verify to the penny what the rates are going to be until we put it all through the system and be sure that it all spits out correctly, and that will not be until middle of November probably, before open enrollment starts. Questions about any of that? Okay, so trying to give you what to expect. Chris, yeah? Oh, okay. Oh, Chris is going to do the question in the mic.
One of the questions I have, and I don't know if any of you have experienced this, is some of my employees have called to say that a drug that they were taking for years that was in the formulary has now jumped to the non-formulary or the more expensive, even though it's the same exact drug. And the pharmacist, this is what they tell me anyways, the pharmacist has confirmed that it's the exact same thing, nothing's changed, it's just more expensive now. And can you address that? That's happened several times to me. I don't know if it's...
Okay, yeah. So drugs moving in the formulary, those decisions are not made specifically at the trust, but with Anthem and their pharmacy team. And they always are looking at their formularies to make changes when necessary. A lot of times if the same drug moves to a higher tier, it's because a generic for that drug has become available. And if it's available, then they're encouraging people to take the generic. But if they continue to take a name brand when a generic is available, then that often is more expensive. They move it up into a more expensive tier. Or other things that can happen is that the company that makes the drug has negotiated the pricing with the pharmacy benefit manager, and there's another drug that does the same thing that is getting better pricing, so they're going to encourage that by putting it in a lower tier than this one. And that stuff happens, and I'm not necessarily privy to why drugs move from tier to tier, but that's a lot of times it's all about the negotiating of the pricing, and the tiers are really about trying to, they reflect the drugs that are more expensive that are in the higher tiers. That's about the best I can explain it, I guess. Chris? Yeah.
So my next question on that would be, is that an Anthem, that's not necessarily a Maine municipal decision, but an Anthem. So in one instance, somebody who was advocating for Teamsters insurance that was also tied in with Anthem said, well, we'll just move to this other plan if you guys are going to start doing stuff like that. And I just want to confirm that it is in fact an Anthem thing and not necessarily a Maine municipal.
Yeah, we don't control what drugs anything falls in the formulary. That's Anthem, and they have a pharmacy team, and they have this huge department that handles looking at all the drugs and which ones are most effective at the best value, and those will often be in lower tiers versus ones that are in upper tiers. So, but their formularies, they do have different formularies, but ours is one of the most wide open formularies out there. We don't restrict people to not getting a lot of drugs, and we don't require them to go to certain pharmacies. We allow any pharmacy. That's very unusual nowadays, actually. So I think you'll find that a lot of our competitors have a lot more restrictions, actually, versus what we offer on our formularies. Steph? Mm-hmm. Yep. So the question was if we'd had any lessons learned or things to report regarding the change from Express Scripts, which was the pharmacy benefit manager before July 1st. And July 1st, we moved to a new pharmacy benefits manager called Ingenio RX, which is actually Anthem's own pharmacy benefit manager. So all of the data, I have had some positive reports from members that they like that all of their data, their claims data now, their pharmacy and everything is all available in one site on the Anthem site with one login, which is nice. And all the integrated information we expect to be very helpful. There were most people reported that the transition went fairly smoothly. They went to the drugstore, and the drugstores knew, and they had software updates, and they knew that there was a new PBM, and they just their prescription processed like it always did. If you had a specialty drug, we had some people who had some challenges with getting that switched over to the new PBM, but it was a fairly small population, and we were able to, member services worked with all of them individually to make sure everything went smoothly and they got their prescription. At this point, we're in September, most people have filled their drug again, so we would have seen if we were having a really big blip or really big issue by now. Mail order, I do have flyers about mail order here, updated, because they would have to send things now to the new Ingenio RX through the new website for mail order. So if you had people participating in the mail order program, they do need to log into the new site, put in their new information and their new payments. So I think there is a little bit more work for people who were doing mail order. But once they do the initial setup, it should be just as simple as it was before, with the reminders. And I actually got a text reminder the other day that it was time to fill my drug. So they do have some nice technology options. Yeah. And all the pharmacy and stuff is all available on the app now, too. So if you go to Anthem's app, you can see your claims, your medical claims, and your pharmacy claims in one place. So that is a positive. Any other questions? I think that was all I have up front. There's some materials. If you want more information, we are doing annual reporting meetings. I am doing one in Augusta on the 24th and in Biddeford on the 25th, and also on October 2nd in Bangor in conjunction with the MMA convention. Those are our reporting about what the trust is doing. Some of the information I shared with you today will be there, but also more detail about our financials and how the trust is doing and what we're, more of our strategic plans. And then the ever popular retiree workshops are being held in October. They are quite a social occasion for many of our retirees to attend, so with donuts. Oh, no, not donuts, something healthy, sorry. I'm on record saying donuts, oh no. So if you would like to attend, you're certainly welcome to as well, to hear what information is being presented to your retirees. Or their second half of it is the so you think you're ready to retire or you're looking to retire, and that's becoming more and more people are attending that as well. So the first half is intended for current retirees on our Medicare group companion plan, and the second half is if you're looking to retire, here's information for you about medical when you retire. So you're welcome to attend any of those, and I have the lists and stuff up here of them, but they're coming out in their next bill as well, the flyer, okay? And they're on the website. And that's it, and I'm sorry we ran long there, but if you have any questions, I think you know how to reach me as well as Ann and anyone else in the Health Trust, and we really appreciate all of your support to administer these plans for your employees and to educate them on the benefits that they have and the best way to get the best value out of them. So, thank you. You guys go with those? Okay.
Okay, so we are going to talk to you today about wage statements, and then hopefully have some time at the end to go over the legislative changes from earlier this year. So a little story about wage statements before I get started. We're very fortunate at Maine Municipal to have one person dedicated to completing our wage statements. She sends out all requests for them. She works alongside you guys to make sure they're completed correctly. She does the calculations and then tells our adjusters and our med techs exactly what to be paying our injured employees. So in preparation for this meeting, I went to Melissa and I said, Melissa, please teach me all you know about wage statements. And we did. We went over wage statements. I took great notes. We completed the cheat sheet that I passed out to you today. But I walked away and I thought, we can never lose Melissa. So if you have someone that does your wage statements, hold on to them dearly. So wage statements are very important for two reasons. The first is that we use it to calculate the compensation rate that we're paying your injured employees. And the compensation rate would be what we would pay to them weekly if they were completely out of work. We don't want that to be underestimated because they're losing out on money, but we also don't want it to be inflated because there's no way we can ever recoup that money if we make an overpayment. So it really needs to be accurate. The second reason it's important is because it is now going to be monitored through the Workers' Compensation Board. I've been doing this for 16 years now, and we've always said the board has the ability to monitor this, they have the ability to assess penalties if it's not completed timely, and now they're finally doing it. So it's very important that our membership have a solid understanding on completing it so that it can be done correctly, hopefully the first time without much back and forth, so that we can get that filed timely with the Workers' Compensation Board. So we actually will make you aware when the wage statement is needed. Melissa will send out the request for it. We also will send out a request to any concurrent employers. Oftentimes we run into, for the most part, firefighters that would have a second job, so it's our responsibility to send requests to their other places of employment as well to get that information. If they are self-employed, we would request a Schedule C from them so that we could take into consideration any earnings from that as well to be calculated into their compensation rate. This needs to be filed within 30 days from the determination that incapacity benefits are owed. So there's that 7-day waiting period for most employees. Firefighters have no waiting period. So it would be day 8 for most employees if they're out over 7 days. The determination that lost time benefits could potentially be owed is made, and then we have 30 days from then to submit the wage statement. Firefighters, it would be from day 1. So how to complete it? This form's very scary. My suggestion would be to work backwards. Looking at the week ending dates need to be the last day in your payroll period, with week 52 being the week of the injury. Wages have to be reported as gross earnings as opposed to net. The earnings can be reported as biweekly. If you have the ability to do it weekly, it makes the form much easier. But I know most people are on a biweekly pay schedule, so it can be completed as such. Just making sure that week 52 is broken down to a weekly amount. Also, the week of hire, if it falls within that 52-week period, that needs to be broken down to a weekly amount as well. And then there's some examples of what cannot be included is sick or vacation buyout, uniform reimbursement, or travel reimbursement shouldn't be included in that form. So we need to file it, as I mentioned, when we determine that potentially incapacity is owed, but we also need to file it if the claim has been denied. And even if no incapacity benefits have been paid, we then still have to file it with the Workers' Compensation Board. It comes into play with the litigation of the claim.
And just to jump in, there's a third scenario where we may request wage statements from you folks when we actually don't have to file it with the Workers' Compensation Board. That's when basically the board tells us if the injured employee is suffering a wage loss, any sort of wage loss because of the injury. So let's say they're working 40 hours a week, but they're unable to work overtime, which is something they normally do, or they're charged sick time by you folks for medical appointments for workers' compensation. We actually will have to track that on a weekly basis until they hit that average weekly wage or comp rate. So it could be a situation where we're requesting a wage statement from you folks. You may be asking, well, why am I getting a wage statement? They're working light duty, but there could be a restriction that is causing them to still suffer a wage loss. So in those cases, we need to get that wage statement in, and then we compare the post-injury earnings to the pre-injury earnings and actually have to calculate that until the person's back to regular duty or no longer suffering a wage loss, which in some cases could be months and months. Some cases it's just a few weeks, and it still would be a medical within waiting period. So that's that third scenario where we're requesting a wage statement from you folks. You may be thinking, why is MMA sending this to me? But that's a scenario where we would have to get wages as well, post and pre-injury.
Yeah, that's a good point. It could even be that someone's working light duty and hasn't lost a full day from work, but they're maybe restricted to 40 hours, so we have an obligation to calculate the difference of what their normal, what their overtime that's included in their pre-injury average weekly wage versus their 40 hours. It could also be, as Matt mentioned, sick time. or just any fluctuation in that amount. If they're not earning at or above their pre-injury average weekly wage, we have an obligation to track it on our end.
And just knowing a lot of folks and doing this for quite a long time, some of our members won't charge sick time for medical appointments for workers' comp. Some people will. It's really an individual municipal decision. We feel if you're going to be charging sick time for medical appointments for a workers' comp claim, then unfortunately you're probably going to get a wage statement because we do have to track those earnings. So even if it's an hour that they had to use sick time to go to a medical appointment, we will then have to get a wage statement and track those earnings and show, unfortunately, the workers' comp board that they haven't met the waiting period. So if possible, we strongly encourage to pay regular wages for medical appointments. We realize that there's some employees that may abuse this, and it causes headaches for you folks. Hopefully that can be managed at a supervisory level, but it does create less paperwork, to be honest with you, for workers' compensation, and also it may prevent a med-only claim from becoming a lost time claim. So.
There are 4 ways, once you have the wage statement completed, to calculate the compensation rate. And the easiest, they're under the statute as section 102 for A, B, C, and D. So A is probably the easiest. It's that the employee has worked with you for the full prior year. We take that full year, divide it by 52, you have their average weekly wage. Currently, we calculate the comp rate by having 2/3 of that average weekly wage. B is, A is salaried, so complete salary. We take their salaried amount, that's their average weekly wage. B is you divide by the number of weeks worked. So they've been with you the full year or more than half of the year, so we feel comfortable with dividing by the number of weeks. That's their average weekly wage. Sometimes you see we push back and say, well, this is a seasonal employee. We need their full prior calendar year. So any seasonal employees, regardless if we're at the tail end of the season, we have to request the prior calendar year. If that's not available, we sometimes move on to D, which is comparables. And that's usually not too easy because some people might put in a lot of overtime, some people very minimal, but hoping to come to a fair average weekly wage and comp rate for that employee.
Just to clarify, that's a lot of times people ask, why is MMA wanting this information? It's really not us, it's the workers' comp board, it's the state regulation. So we're just following the state regulations that are outlined to us to make sure we're in compliance with the state and the regulations set forth. So we fully understand wage statements are either for you folks or your staff who does your wage statements are really a pain and time consuming and not the funnest thing in the world. And we really appreciate the time and effort that you guys take to do it. But just keeping in mind, it's not MMA kind of driving that, it's the state requiring us to get this information done timely and correctly.
And for the most part, if we can come to the fairest decision on the comp rate, we're able to talk that out with the injured employee. Usually if we can come to an agreement by all parties, it's usually acceptable by the Workers' Compensation Board. What we are, and Matt's going to talk about the reconciliation report and the wage statements being included in on that, but we are seeing a lot of pushback now from the Workers' Compensation Board as we submit these forms, calling us and saying, well, we don't agree with how you've calculated this. There's zeros in there. We think they should be taken out of the wage statement. Or we think this is seasonal, even if they worked more than 26 weeks in the year. So we are getting a lot of pushback. And we just need to be able to feel confident that we're handling scenarios similar and fair, and then just being able to support that with the board. So Matt handles our reconciliation report. We get it quarterly from the Workers' Compensation Board. There are certain benchmarks that we have to meet, and if we fall below those, it could warrant an early audit from the board. One being the timely filing of first reports, the timely payment if there's lost time on a claim, and most recently they have added wage statements to that.
And notice of controversies filed timely.
And notice of controversies. So Matt, if you want to talk a little bit about.
Sure, we kind of just explained the whole thing.
Sorry.
So basically, we get a quarterly recon report, what we call, from the Workers' Compensation Board, and like we were talking about it, basically it goes through first quarter, second quarter, third quarter, fourth quarter, and every claim that we've received from our members, including our broken down by, we have 2 TPAs, so it's MMA and our 2 TPAs kind of split. And basically, I have to go through that whole report and identify any issues that the board feels needs to be corrected or additional information needs to be provided to them. It's also the time where we get our Section 205(3) penalties, if anything, which is basically if we don't issue a payment to an injured employee within 45 days or we haven't denied it. So we very rarely get those, but in some cases we do. So basically it's a quarterly cleanup of the information that we have for workers' compensation. Like we were saying, prior to this next quarter, the history was to track if we made payments timely, if we filed our memorandum payments timely, if we filed denials timely, but they now are adding if we have filed our wage statements timely. So once they let us know that, we reached out to Don Brewer, and we just wanted to get out in front of you folks to kind of reiterate that, again, we know wage statements aren't everyone's favorite thing. It's not ours either. But there's going to be a higher level of scrutiny from the Workers' Compensation Board to get those filed within the 30 days. So we just wanted to get that information out to the membership and our TPAs that although 99% of the time you guys do awesome, they're filed timely and actually really quickly, going forward there's going to be again a higher level of scrutiny from the Workers' Compensation Board, including the board tracking those to our benchmarks. Again, if our benchmarks dip below a certain level or percentage, we run the risk of an early audit from the Workers' Compensation Board, which is not a fun process. The only other thing I did want to add too is I know we have 30 days, and for the most part, you guys file it much sooner than that. We really don't want to wait to the 30th day, especially if we're paying the claim, because as Tracy said, we want to make sure we're getting the benefits out to the injured employee timely and accurately. So we don't want to have to send a provisional payment to our injured employee, which is basically our best guess of what his or her earnings may be, and then have to correct it, keeping in mind that provisional payments are usually lower than what the actual comp rate should be. So again, the quicker we can get it back, the quicker we can get the injured employee paid. It's just a better scenario. So you do have 30 days, but we strongly encourage, and for the most part, everyone does a great job of getting that filed actually really quickly. So.
In addition to the reconciliation report, the board right now only files penalties for late filing of the first report of injury. It's a $100 penalty if it's not filed within 7 days. They do have the ability to add wage statements to that penalty, but I don't know if that's going to be enforced just yet, or if they're going to see how things pan out with the reconciliation report, but that could potentially be coming down the pike as well. So for any wage statements not filed within 30 days, there could be a $100 penalty assessed to that. So in an effort to help with completing them and getting them filed timely, I know when Melissa sends out a request for those, we do have a cover sheet that gives you some tips on completing it. Melissa and I sat together and did this cheat sheet, more to focus on the biweekly because that can get a little confusing when you're working backwards and making sure to split the weeks. But certainly, if there's ever any questions, contact Melissa. No, Matt and I are always available. Matt and I are always available.
You can call anyone.
Anyone.
Your adjuster, Melissa, us, and we'll do our best to help you.
Yeah, certainly. We do, even though Melissa is our dedicated person to these, we all have an understanding on how they need to be completed. It is essentially the adjuster's job to make the final decision on what's being paid, so sometimes they may even differ from what Melissa has recommended. So give us a call if you need help at all. Any questions on wage statements, or move ahead to the legislative changes? So we can go over this real quickly. It was a very busy season for comp at the legislature. We did, I believe in our last Townsman, publish an article on the changes. So if you're looking for something that covers that, I believe that was in our last publication. But a lot of changes that will affect how we manage claims come the start of the new year. So if just go over those quickly.
It's a cost increaser, so that's the biggest thing you guys will see. It was a compromise, I guess, omnibus bill.
It could have been worse.
And it could have been worse
It's
with some
still
of the things
not
we're
great.
proposing.
And it's really, not many of them are going to impact us immediately. It's more looking into the future and the final cost of claims. So the first one, we pay at a max benefit rate, which currently is
$57 and change.
$8.57. That is equivalent to 100% of the state average weekly wage, and that is going up to 125%. So that will be an immediate impact that essentially brings up the current rate to over $1,000.
Yeah. Well, immediate, it's starting 1/1/20.
Yeah, all of these are starting in the new year.
And I think the reason why that's important in the municipal world is you guys have high earners, and we see it all the time, keeping in mind that a lot of folks, especially the firefighters, have concurrent employers, so they could work full-time for you or part-time for you and have a concurrent employer that is a full-time firefighter or fire department or vice versa, and they are extremely high wage earners. There's other folks also that are high wage earners, so this will directly affect the cost of your workers' comp program because we insure just such high wage earners.
And that amount's adjusted every July 1st. So you'll see it's going to be increased anyways, but every July 1st, it typically goes up about $20 to $30. There is also going to be a new cost of living adjustment. COLAs are pre-93. We haven't had to deal with them for a long time, but they have brought that back. The good news, I suppose, is that COLA won't come into play until you've paid 260 weeks of total benefit. So under Section 212, which is total compensation, you have to pay 260 weeks before you start applying a COLA to the compensation rate. So for the most part, claims are resolved within that amount of time. This is really going to impact more of those traumatic injuries where the person goes out of work completely with little expectation to return.
And it will increase the value of settlements. So a lot of times, hopefully, we can settle a claim within 5 years if it's trending that way, if they're not back to work and 100% fully healthy. But when we're making the analysis of the settlement and calculating the future exposure for lost time benefits after 5 years or the 260 weeks, that's where the increase in the cost of a settlement will take place.
Mm-hmm. We're unsure how that will work with max comp rates. Mm-hmm. So we're still learning on that one. The durational limit for partial is currently set to 10 years, and that has gone up to 12. So that will also impact how we value claims for settlement. But essentially, if someone has a work capacity and you're paying them at a partial rate, we were always able to cap that at 10 years. So at the end of the 10 years, for the most part, you're able to stop paying that person, and now that's been extended another 2. So that will come into play when we're factoring a claim for reserve increases or looking at it for settlement purposes. So this one is, and they have a spouse, they're entitled to 500 weeks of death benefits. If there's no spouse but children under the age of 18, they're entitled to death benefits as well. So this change indicates that if there is no surviving spouse, there are no dependent children under the age of 18, parents can apply for benefits and could qualify for that 500 weeks of death benefits, which is a little perplexing should they have a child that's 19 and may not be a dependent, but maybe still relies heavily on their parents, why they wouldn't be entitled to these death benefits as opposed to a parent of the deceased. So,
Or it could be a 60-year-old public works guy who's divorced with no kids but has 80-year-old parents, and he passes away at work for whatever reason it's compensable. Those retired 80-year-old parents will get potentially 10 years of workers' comp benefits. So unfortunately, this is a law that was enacted because of two tragic situations that happened, MMA insured in the last few years with first responders passing away in the line of duty. They both were relatively young guys, and they weren't married and didn't have kids. What used to happen is if they didn't have any dependent children, we would owe a certain amount of money to the Workers' Compensation Board to fund a vocational rehab program. Some folks didn't think that was fair, that there was no benefits at all paid to anyone but the state. So there was a big push in this last session to correct that. The correction seems kind of odd because there's a lot of scenarios that could come into play. But that's the law that will, and actually this one is retroactive to 1/1/19, specifically because of one of our claims that the person didn't have benefits.
Retro, though, in the sense that whatever was paid to the Workers' Compensation Board now has to be handed over to the parents. So this new law is only 1/1/20 going forward. So. Some systemic changes that will impact how we handle claims. Currently, we have 14 days to pay or deny a claim, which isn't much time to put an investigation into a claim if you really think about it. By the time the claim's filed, we start talking to parties involved. But if we were to issue payment on that claim within the 14 days and then some fact comes forward that leads us to believe the claim isn't compensable, we can't just stop paying the claim at that point. We have to file certain paperwork. It's called the 21-day discontinuance in order to stop. And then we have to continue paying that person for that 21-day period before we can stop paying them that benefit. What this new rule change indicates, it's, I guess, a 30-day buyer's remorse type thing. You have 14 days to pay or deny, so you pick up the payment on day 14. You then have an additional 30 days to change your mind. So, and without having to file the 21-day discontinuance. So within that 30 days, you could essentially say, we found out this information, we don't feel this claim is compensable, and at that point, you can then issue a denial, and then I assume they haven't really told us yet, just the standard discontinuance. So that may help. I don't think there's many claims that we pick up that we then turn around and say, oops, we shouldn't have done that. Usually we're pretty confident in the decision we're making. It's usually down the road that if a claim isn't going to be compensable, it changes at that point. So that may be helpful. I know there's going to have to be a lot of discussion on how that actually works out. And I think that was the only,
So notice is going to go from notice of injury by injured employee will be 60 days. So it used to be 90 days, went to 30 days, now it's 60 days for an injured employee to notify you of a work-related injury. So it's a little change. To be honest with you, the environment that we live in currently in workers' comp, notice is a tough nugget to win on anyway. So our standard, what we tell our members is even if an injured employee comes to you and says that injury happened 6 months ago and you guys are aware of the notice in injury, if the employee is asserting the claim, definitely file the claim and we'll do the investigation and we'll go over the notice issue with them. What we don't want you guys to have to do is, go over that whole notice issue with the injured employee. Plus, if they're asserting a claim at the end of the day, whether it's within the 60-day period or not, the claim still has to be filed and we still have to do our full investigation. We'll use notice as a defense, but it's just something to keep in mind if this happens with one of your employees, so.
and lastly, we are able to offset sick time if someone is on a varying partial. We can offset any sick time used if they go out of work for an unrelated flu or something unrelated to their work injury. We can offset that amount. We cannot offset for vacation. And paid time off was always a gray area, but they have decided that paid time off is offsettable as well. So that is something we can use to offset the compensation rate we're paying them. And I think that's it. It's a lot, but we'll see how things go come the start of the new year with managing these claims. Any questions on the legislative piece?
Or wage statements or
Anything at all?
on workers' comp questions.
Okay. Thank you.
Thank you.
And back up, because a question came in from someone who was watching.
The question is, question on lab work and Lyme disease for an employee, not work-related. Are there any changes in the plan to allow different labs to test for Lyme?
It's not something that I would know anything privy to, I'm afraid. Different labs for Lyme. That's a matter that they should either have their provider call member services about, or they should call member services and we can help work through that. But as an individual situation like that, if there's different labs, if they've been approved, there's new treatments being approved, then they're working through the process and they would be covered services, but I don't know of any specific new labs related to Lyme. It's certainly, we're very aware that that is an issue that has become more prevalent in the state, the whole tick population and all that. So we've certainly been doing quite a lot of education actually around the ticks. The wellness team has some classes, Tick Talk it's called, I think. They always have these cute names, don't they? So if about that and about the hazards and the symptoms of Lyme and stuff like that, but someone who's already dealing with trying to be diagnosed and treatment, they should call member services and talk to them about what they can get for treatment, okay? What's covered.
Just to throw in the workers' comp piece, we are seeing a significant increase in workers' comp claims for tick, and unfortunately not a lot of Lyme disease, but we strongly encourage preventive measures by all your employees to help prevent those claims, because some are minor, some don't, but some can turn into very costly, in some cases litigious claims for a lot of different reasons. But it is something we're seeing on the workers' comp side.
Yes, so further education, and we have the little tick removal spoon things. Wellness has those. We can provide those if you'd like some of those, and education and stuff is something that we can provide to help keep your workers' comp exposure down as well as keep your employees healthy. So, Yeah, big issue. Lots of questions about. We talk about bugs way more than we ever used to. So, any other questions anybody had for workers' comp or for me? I did want to point out on the table here some notepads and pens if you'd like, and also when the retiree workshops and annual workshops are. But I also have the walk-in center list and the mail order list, and copies of the letter that went out in August. So I'll leave some of that for you.
Thank you guys so much for coming and presenting to us, and there's always so much valuable information. We're really lucky to have such really wonderful staff up there. Just, I think, both teams at MMA and the Health Trust are just really, really, really great resources and great people. So thank you.
This presentation will be on YouTube, probably by the end of the day. I'll send word out via email to everybody when it's available. And please eat. Grab stuff on your way out.
Yeah, we'll take a quick break, maybe 5 or 10 minutes for a little bit of food, and then we'll come back for a short roundtable discussion.